I'll be your MC for this afternoon's webinar. Please go ahead and introduce yourself in the chat box. Give us your name, your organization, email address, and if you would like us to add you to the CQUIN corporate WhatsApp group, also add your telephone number. We are going to be using the Q&A box for questions. So we will not be taking presentations after, questions after each presentation, but go ahead and type your questions in the Q&A box and the panelists will respond in real time. So at the beginning of the 1990s, as the HIV and AIDS exploded in Africa, those of you who were old enough to remember, we witnessed a lot of deaths, a lot of devastation from HIV, leading to countless orphans and vulnerable children. And during that time, we realized that the HIV response, which was primarily restricted to the health sector, was not enough, was inadequate for the comprehensive response that was needed at the time. So the mounting pressure from this devastation, which was beyond health and on populations and communities across Southern Africa, then led to the multi-sectoral approach. Over time, this multi-sectoral approach moved from being just rhetoric to becoming national and donor strategies. Now with COVID-19, and the situation of lockdowns across many countries that we are experiencing today, the importance of this multi-sectoral response cannot be overemphasized. So on today's webinar, we are going to hear from 4 countries on how they are tapping into this multi-sectoral approach to ensure that there is uninterrupted antiretroviral therapy and other relevant medicine supply for people living with HIV. So these are the format of the presentation. We are going to hear first from Kenya, Dr. Lazarus Momani, who is a national DSD advisor, who will present on behalf of Kenya. And then it will be followed by Dr. Ms. Samrata Togwell, who is the Deputy Program Manager for the National AIDS Control Program Liberia. She will speak for Liberia. This will be followed by Dr. Aaron Vande, the National ART Coordinator for Sierra Leone. And then Dr. Harvey Kambale, who is the DSD advisor. And Dr. Nompilo Gwebo will share the presentation for the Kingdom of Eswatini. So may I now invite Dr. Lazarus Momani to make his presentation. Dr. Momani, please take over.
Thank you, Peter, and everyone, good afternoon from Nairobi, Kenya. So on behalf of the Kenyan team, I'm going to make a short presentation on how we are collaborating as the Ministry of Health with some of the security agencies to ensure that we are able to facilitate community ART distribution during the COVID-19. And in my presentation, I'm going to highlight one of the counties that is affected by some of these restrictions. Next. So a little bit of background. The first case in Kenya was detected in 13th of March. And as to date, we have had a total of 912 cases confirmed with the recoveries of 37% and a fatality rate of 6%. 50 patients have died. And if you look to the left upper of my slide, you will see actually the progression on some of the cases. And we had a peak of the cases about 3 days ago when we had, because of some of the issues of truck drivers crossing from some of the neighboring countries in Kenya, which has now led again to some of the borders being closed between those countries and Kenya. In total, we have had about 22 of our counties being reporting cases, but the most hit counties is Nairobi and Mombasa. That in between the 2 counties, we now have 84% of the total cases reported in Kenya. So as part of the containment measures for the government of Kenya, on the 6th of April, they issued what we call a cessation of movement into 4 counties. And on the map, you can see the maps highlighted in red of Nairobi, Mandera, Kilifi, Kwale, and Mombasa. That now, because of this restriction, there's no movement in and out of these counties. And later, this was extended to the county of Mandera. And in addition to this, you also have the dusk to dawn curfew that has now been extended to 6th of June. So in Kenya, we have actually a partial lockdown in these 5 counties. Next. So now, what has happened because of some of these restrictions and how has it affected HIV service delivery? One is that we've had, of course, the recipients of care in these counties, they've had challenges, initial challenges in terms of accessing ART services in some of the facilities, especially those along the borders and across the roadblocks. Some of the recipients of care reported that they had actually traveled out of these counties before the cessation of movement was issued, so they were unable to come back to be able to access the mother facilities. And even for some of the healthcare workers, as much as health has been classified as an essential service, we've had initial scenarios where some of the healthcare workers, they were not able to work very well with the police, and therefore they were not able to access and be able to move to where some of these recipients of care is and to provide services. Next. Just to highlight some of the general strategies that as the Minister of Health we have recommended to be able to navigate through some of these issues. One, there was a circular that was issued on the 24th of March, and through this circular, we recommended that all our recipients of care, regardless of their viral load status, they be able to be issued 3-month refills for their treatment. And we also recommended that facilities should scale up as much as possible community ART group and even home distribution of ART by working with some of the different cadres of healthcare workers, peer volunteers, and even community health volunteers within the facilities. We also recommended that for circumstances where some recipients of care are not able to access their original facility, then there should be some inter-facility linkage where they can be able to access their treatment from any other facility of their choice where they're able to reach at that given point in time. Next. And so just from the map alone, you can see in red, in green is the Nairobi County, which is one of the locked down counties, I would say in quotes. And you can see the red boundary is where now roadblocks were erected by the police to ensure that there's no movement of people in and out of these counties. And if you can see to the south, you have the county of Kajiado, which is cosmopolitan and next to Nairobi. And the roadblocks were actually just erected in part and in middle of and splitting the county into 2. So what this meant is that some of our clients were not able to move across some of these roadblocks in the surrounding counties of Nairobi, and therefore they were not able to freely access treatment. And so what the facilities did that initially they did mapping of all the recipients of care in these facilities around the roadblocks or near the borders, and they were able to map them to their location and be able to link each of them to specific community health volunteers and healthcare workers within the facility. And through an engagement within the county health teams and the Ministry of Interior through the county security offices, they were able to get special passes to be issued to the CHVs, that's the community health volunteers, the peer educators, and even some of the health volunteers to ensure that, and the health workers to ensure that now with these passes, they're able to access treatment from the facilities and be able to move freely within these borders to be able to reach out and deliver ART to the patients wherever they are within their homes and within their groups. Next. And so you can see in this map here, this is a map of Kajiado, and you're seeing this is the distribution of the facilities, the ART facilities. In red are all the ART facilities, and in green are the facilities that are having this model of community ART distribution within the communities and within the homes. And some of them you can see actually along the borders. So they've been able to move across these borders by just being able to show these passes to the police and be able to move. So in total, we've been able to engage within the county 79 community health volunteers and healthcare workers. And they are able to collect treatment from the facility and be able to deliver to the homes and the community health groups and be able to navigate the borders freely because of this close engagement with the security forces. During this distribution, they're also able to deliver Septrin and even a TB preventive treatment. And because of the facilitation of the movement, some of the IPs and the MOH and as MOH have come in to facilitate with the stipends for transport and motorbike fuel. Next. Next. And so this is the model that we are using. So the CHVs are able to pick the treatment and fill out this ART distribution form and be able to deliver ART to the community. And during the distribution, they're also able to provide HTS through APNS, pre-exposure prophylaxis, and even viral load sampling, though this is facing some challenges in terms of logistics. And in total, we've been able to reach 1,500 of the patients within this county. And this contributes to about 14% of the total plans on ART within these target facilities. And on the left, you're seeing the modified form that we are using to distribute ART. Next. So in concluding, my last slide is that I think during this period of COVID-19, we have learned that we really need to be innovative to be able to navigate some of these restrictions brought about by the COVID containment measures. And this needs for us even to engage with multi-sectoral other sectors outside the health docket. And we also realize that we really need to continue refining the models we are using to ensure that we are providing kind of a one-stop shop services for our clients, including lab monitoring, delivering family planning, and even other treatment for NCTs. And finally, we also need to look at some of the tools that we are using to ensure that they're able to account for all our clients in these models during this period. Thank you so much.
Thank you very much, Dr. Momani, for that interesting presentation from Kenya. Our next presentation will be by Dr. Ms. Samantha Caldwell, the Deputy Manager for Programs NDCP Liberia. And please, a reminder to those of you who just joined us to please introduce yourself in the chat box, giving us your name, where you work, and your position. And if you would like us to add you to the CQUIN COVID WhatsApp group, please also add your phone number. Thank you. Ms. Caldwell, about to you.
Thank you, Dr. Preco. So for Liberia, we are providing home delivery, and this has been an initiative from bottom up, started by recipients of care, started by networks and the facilities when we identified that many of our recipients of care could not access services because of the COVID-19. Next slide. So Liberia has a partial lockdown. This is inclusive of a curfew. So what that means is there's allowance of movement for essential things like food and medication up to 3 p.m. And from 3 p.m. to 6 a.m. the next morning, there is no movement allowed. Police enforcement of this lockdown is done through checkpoints beginning at 3 p.m. And there's a total restriction of movement between counties. Movement from one county to another is not allowed. Next slide. With the lockdown, what we saw was there was an increase in transportation costs. So with the limited time allowed for movement, cost of transportation increased for not only the recipients of care, but also the healthcare workers. Clinics were now open only for half of the day from 9 a.m., 8 a.m. up to 12 midday to allow for staff to go. Staff at facilities were also running shifts now, whereas the outpatients and ART clinics will have more than 2 to 3 clinicians available. They were now running shifts on days, and there were also a reduction in the volume of recipient of care that could be refilled per day because of these shifts and because of the reduction in clinic hours. Next slide. So with the onset of the COVID-19 in Liberia and the restrictions, we had a meeting with some of the IPs, especially facility-based IPs, and we identified that community delivery of ART had already been initiated by a lot of the recipients of care and also healthcare workers within the facilities. So we, as the program in the Ministry of Health, we then recommended that this community delivery of ART continue, and that 3 MMD be used to refill all of our recipients of care with the exception to new initiations and those with advanced HIV disease. We then worked closely with the supply chain unit to ensure that there were ARV stock at all of the facilities, so we did not have stock out during this period. For those recipients of care who could present at the facility, there were fast-track clinics initiated so that more people could be seen and refilled within a shorter working hours. And then community deliveries were encouraged using expert recipients of care at the facilities, mother-to-mother peer counselors, peer navigators, and other volunteer recipients of care. We also use networks, especially for key population. The network of transgender in Liberia was really very key with this initiative. So what we use for data collection, the recipient of care passports were used to record refills, and these were then transcribed to the ART charts and onto the ART registers. Next slide. So key collaborating sectors, like I mentioned, the Ministry of Health and the supply chain unit, and also the supply chain partner, Chemonics, was able to work closely to distribute the ARVs to the facilities to ensure there was no stock out and to ensure that the 3 MMD was able to spread out to all recipients of care. Key other partners included the Population Services International that runs the Drop-In Center, FHI 360, and the Transgender Network of Liberia. So these partners supported the refill using their own peer navigators, using their peer educators, in addition to the mother-to-mother peer counselors and other volunteer recipients of care at the facilities. So the reach was basically zonal. Peer navigators are assigned to zones, and those peer navigators in the network of transgender reach out to recipients of care in their networks and in their zones to inform them of the availability of the service, and then the pickups were done from the facility to an agreed point in the community or to their homes. Next slide. Next slide. So the community delivery approach, as I said, in Liberia has been a bottom-up initiative. This was really picked up and moved on by the recipients of care and the clinicians at the facilities. So as the program, we identified this model that was being used and encouraged it to improve access. So it was the sole initiative of these networks. There has been no remuneration or incentive for services. Within the time frame provided by the security systems, the network moves to provide the refills to the facilities, to the recipients of care. At facilities where there are Global Fund supported motorbikes, recipients of care at those facilities then use those motorbikes to go to further distances within the shorter period of time to do home-based delivery. Those benefiting from the home-based delivery were mostly recipients of care within the zones of already working peer navigators and mother-to-mother peer counselors, or within their communities, and then facilities and clinicians then use the motorbikes to reach out to longer distances. Next slide. What we have seen with the recommendation of the home-based delivery, we have seen continued access, so little or no interruption of ART refills, because without this, recipients of care who could not afford the hike in transportation or the simple fear of infection would not have been able to receive their refills within the time frame provided. There has been minimization of potential missed doses. So because these networks and recipients of care in the IPs are reaching out to those who are at home, we have been able to provide refills within the time frame and avoid interruption or missed doses of adherence. And then there's also reduced congestions at the facilities. You do not have as many recipients of care needing to present to the facility for refills. And also with the fast track of the refills, you have less and less presenting, but we know that they have received those medications at their homes and within their communities. Next slide. So moving forward, the national program and the ministry has recognized that this is a really great initiative to improve access and to differentiate services as much as possible for the benefit of the recipients of care. So we have begun considerations for standardizing this approach and supporting evaluation and measurement of the quality and the impact of this approach. We want to look at standardizing entry and exit criteria so that we can be able to adequately measure the achievement of the desired outcomes. We know there are potential risks and challenges, so we want to monitor as best as we can to ensure that we can reduce those risks. And with it happening now in COVID-19, we look to moving it out to even more facilities, not only in the urban areas, but in the rural areas to get more recipients of care benefiting and involved across the national platform. Thank you so much.
Thank you very much, Samrata, for that nice presentation. Our next, sorry, Samrata, please, just a reminder that there are questions for you in the Q&A box. So please, as you catch your breath, please do not to respond to them.
Thank you.
Our next presentation is from Sierra Leone, to be presented by Dr. Aaron Vandi, the National Heritage Coordinator. Dr. Vandi, please.
Thank you, Peter. Good afternoon, everyone. Today I'll be talking about home delivery of ART during our lockdown in Sierra Leone. Next slide, please. So sometime in April, the government of Sierra Leone started instituting COVID-19 containment measures, which included partial lockdown of the country. It was mainly done into districts level, and also curfew from 9 p.m. to 6 a.m. And we also had a ban in public gathering, including churches and mosques. And also sometime last month, we had also a complete lockdown for 3 days. And also in May, we also had a complete lockdown for 3 days. So during this lockdown, we decided as a program to ensure that we don't have a gap in delivering services. And we came together and started thinking about how we can get our clients, our recipients of care, receiving the drugs even when at home. So during the first lockdown in April, that's when we started doing home delivery. We decided to extend our DSD implementation to their homes. So since then, we've had a total of about 741 recipients of care who have received drug refills at their homes, and we continue to advise the recipients of care to contact us in case they need home distribution of their ARVs, and also some other services rendered within the clinics. Next, please. Next slide, please. So during the time of complete lockdown, we secure passes for healthcare workers from the National Emergency Operating Center. Currently, we have an e-system where we can go online and apply for passes. We have both vehicle and personal passes and individual passes. So this is done for healthcare workers, and the request is usually done either by program or by even the DHMT, and different individual people can also request for that. But for our staff, we usually do this for them and ensure that we do have a system in place in case there's a complete lockdown. For now, we do not have a complete lockdown, but when we had in April, we our clients usually call us for refills, and we ensure that, like, with the support from our partners, we go into the community and ensure that they get their refills done. And during the partial lockdown, which we currently have in the country, at the facility, our staff usually go through the registers and check for clients who are due for refills, and they call them and ask for their mode of distribution. So they're given the option for home refill or facility refill. So usually some of them opt for home refills. For those who don't feel comfortable, we allow them to come to the facilities, and we ensure that, like, these services are fast tracked, and we continue with the 3 months MMD. And this is usually done by our HIV counselors or the expert clients, and also community health workers within these different communities. And we also get support from our partners, both logistic and HR support, to ensure that we cover more people area during the distribution. Next slide, please. So we have been working with various sectors to ensure the scale up of home delivery of ARVs. And one of our main contributors has been the district health management team. So they usually have their community outreach programs for malaria, nutrition, and other services on a monthly basis. So we usually now join them during this service, during their outreach programs, to ensure that, like, also when they're going out in the community, recipients of care also can receive their drugs during this period. So this is very good for us, because during this time they go as a group and there is no stigma of just HIV, and people don't know even what services they're rendering. So we just go in and not just give them ARVs, they also receive their malaria prophylaxis and also nutritional services, including also TB drugs. So this is very good model, which is happening right now in most of the districts. We have about 16 districts, even though some districts we have not fully implemented this, but majority of the districts have started doing this, and it's working well so far. We also rely a lot on our implementing partners. They have been very supportive, offering technical, logistic, and HR supports. They've helped us with reviewing our guidelines and SOPs for HIV services during the COVID-19, and also providing logistic support. Most of the time during a complete lockdown, they give us vehicles and also a personnel to go with in the district. And this has improved greatly on the coverage and effectiveness of the teams. We also work with the network of HIV positive in Sierra Leone. This is a very small group, but it's very productive, because they know exactly where the clients are. So especially for the recipients of care, for the ones we don't have their contact information. In some of our districts, it's very difficult to get like network connectivities and even to know where they are, their addresses. But within this community, they know themselves, and it's very easy to communicate within this community. So we do rely on them greatly. And even before the lockdown or coronavirus and pandemic, we've been working with them, and now it's easier for us to communicate through them and for them to help with the distribution of ARVs. So as always, it's very confidential, and it also depends on what the recipients of care decide to use. So if they prefer getting these refills through their community group, we do that. Or if also they prefer doing it through the facility, we give them the choice to choose whatever means they prefer. But this has been very helpful for us, as we have more people now doing distribution, and we are covering more area in the country. And we are integrating a program with the TB program, not just for distribution of drugs, but also even the community health workers. Now we are having an integrated program to ensure that, like, we have more people. We only have about 290 community health workers, but the TB program has over 1,000 community health workers. So when we combine both of these people, we have more community health workers in the community, so we can reach more people, and this has been very good for us. We haven't fully scaled it up to all the other districts. We have about 7 high burden regions where we have the community health workers working, but by the end of this year, we would have expanded to all the districts, and this will help also. This has helped very greatly with the community drug refills, and we're trying to work with the program also to synchronize the drug refills so that our clients receive both ARVs and their TB medication for those who are eligible for this. So this is what we've been doing in Sierra Leone so far. In case you have any more questions, please feel free to write them in the Q&A and I'll answer them. Thank you.
Thank you very much, Dr. Vandi, for the nice presentation. I think I have already questions for you in the Q&A box. So please do well to respond to them. There are also other questions for Kenya. So Lazarus, please, if you look into the Q&A box. Thank you. So our next presentation, our last but not the least, is from the Kingdom of Eswatini, to be presented by Dr. Harvey Kambali, the National DSD Coordinator, together with Mrs. Nopilo Kwepo, who is the Adherence and Psychosocial Support National Coordinator, also a recipient of care herself. So over to you, Eswatini.
Okay, thank you, Peter. So I'm going to present on behalf of Eswatini. Next slide. So on the 17th of March, so His Majesty the King Mswati III declared the COVID-19 as a public health emergency in the kingdom. And since then, a full lockdown have been implemented with police enforcement at different checkpoints around the country. So only essential services have been allowed to operate. This included facilities, food outlets, and other services, including water and electricity supply. So after the COVID-19 have been declared as an emergency, so the National Disaster Management Agency have become responsible for the overall response against COVID-19. Next slide. So as a consequence of the full lockdown, so public transport have been disrupted and services are limited only for morning and evening. And this has affected recipients of care ability to reach their facilities, as now most of the facilities are experiencing unusual increase of the number of missed appointments. Like, for example, one of the facilities which has an average of 200 clients per day has recorded during the lockdown less than 50 clients because most of the clients missed their appointments. And at different checkpoints, police officers unintentionally access medical records while trying to ascertain why people were traveling or were on the roads because they've been asked to stay at home. And this has been a problem because it's a problem of an intentional disclosure of the HIV status, because while they were trying to prove why they were traveling, so recipients of care have been forced or requested to show a proof, and this includes even the ART booklet. And in some checkpoints, they were even asked to check specific dates of the visits just to ascertain the veracity of the information that they are going really to a health facility. So this has been a problem, and there were many complaints which has reached the program. Next slide. So as you can see on the top of the slides, I've illustrated recipients of care who have been turned back at different checkpoints. And this is because either they were coming to the facility, traveling not on the specific day of an appointment, or some of them were not able to disclose their status, so they couldn't show their ART booklets. So after they've been turned back from the checkpoint, most of them called their facilities, or they call their network, or some of them even call directly the national program to the focal person. So after the complaint has reached the National AIDS Program, so there were a meeting between the National AIDS Program and NATURE, which is the National Multi-Sectoral HIV Response, and the COVID-19 Regional Response Team. So the three organizations met and put together a statement which was presented to the Minister of Health. And then later on, the matter was taken up to the Office of the Deputy Prime Ministers. And after that, the government engaged the representative from the police, and as an outcome, a multi-sectoral response team have been formed to take care of this matter. So the police office has shared an emergency line to the media, so that clients who have been facing problem and different checkpoints could call the number so that they can be helped. And also most of the police officers at the checkpoint also oriented on how to make confidentiality of information of recipient of care. Next slide. The outcome. So in some of the major checkpoints, health workers have been deployed to assist the police in this matter. So they are actually assessing people who are saying that they are going to a health facility. So healthcare workers are checking if it's true that they are going to health facilities. And as I mentioned, an emergency line from the police have been shared through the media so that recipient of care can call in case there is any problem and any checkpoints. So this number is decentralized. So there are police commanders in each region who are responding to the calls from different clients. And also facilities have been asked to assist recipient of care with a blanket letter or note so that they can be used, that note can be used for the next or the visit following that visit. And also the country and the program is scaling up community commodity distribution. This includes ARVs, NCDs, drugs, TB drugs, and other commodities. And implementing partners are supporting the outreach field so that recipients of care who are not able to reach facilities because of lack of transport can access their treatment. And recipients of care are also allowed to refill where they have been logged as visitors because most of the companies are closed. You might find that recipients of care are now have been locked down in their villages, so they can refill at their nearest facilities or at the nearest points of the community drug distribution. So currently the program is also working on assessing the mechanism to provide access to treatment for clients or recipient of care who have been locked down outside the country. So this is an initiative which has started in one of the facilities, which is currently providing care at one border, so with the South African border, so that clients who have been locked down to the other side can access care. I think that is my last slide. Next slide. So I would like just to acknowledge the support from different partners who are working closely with the Ministry of Health to try to control and the COVID-19 pandemic. Thank you. Over.
Thank you very much, Dr. Kambale, for that very interesting presentation, highlighting how you're working with the police to ensure that recipients of care can access ART. I see that all the questions have been answered. We still have about 15 minutes to the end of the webinar. If you have any questions, maybe at this point, you will raise your hands and we can call you to answer, or you can still go ahead and type in the Q&A box. While we wait for that, I would like to ask the panelists to just share with us whether these relationships that they have described with the sectors they mentioned, whether they are new or existing relationships.
Hello? So for Liberia, many of these relationships were existing, but not being used for community refills. So currently the partners that have been involved, the PSI, the Transgender Network, and the linkages, FHI 360. FHI 360 and PSI were implementing partners for facility-based care and also increasing access for key population. And through them, we also engaged regularly with the Transgender Network for access to services for the population, HIV testing and treatment. So these networks already existed. This was just an opportunity, and they took the initiative of the existing network to roll out the community approach.
Thank you very much.
Thank you, Peter. For Kenya, Yes, some of the relationships were already existent in terms of just engaging between the partners, the other stakeholders, and the Ministry of Health. But I will say that I think the engagement with the police has been really necessitated at this time during the COVID-19 because of the restrictions and the roadblocks and the issues of curfew, as really necessitated for us now to engage more with the Ministry of Interior and even the security forces to ensure that there's free access and movement during this COVID-19 for our clients and even for the healthcare workers. And as we speak, I think even some of the other discussions that are happening is how we can even engage them in a more structured way, sensitize them, even to bring in issues around even how they can facilitate women who need to are in labor during curfew time, how they can be able to move freely, and even skill delivery and other issues in health just beyond HIV. Thank you.
Great. Thank you very much, Dr. Mani. Any other contribution to this question?
So for Sierra Leone, some of this relationship were already existent before COVID-19 pandemic. However, one thing we've noticed is how important these relationships are and why we need to strengthen them. So I think this is even going to go beyond COVID-19 because it's very good for us to continue with our differential service delivery. This is something that we've been planning to improve for a long time, and during this time we're fast tracking. So I feel like this is a very good time for us to strengthen this relationship and to use them in the future for our HIV activities. So all of them were already existing except the one for our relationship with the Emergency Operating Center. And so this is what we've been doing so far in Sierra Leone. Thank you.
Thank you very much, Dr. Wandi. Eswatini?
Yes, for Eswatini, that relationship existed before, but it was only limited to the key population unit. Because as you know, in Eswatini, being key population is a criminal offense. So the key population units from the AIDS program was closely working with the police to sensitize them so that key population are free. And we have discovered that working with different units in a multi-sectoral approach is one of the key consideration we'll keep even beyond COVID-19. Maybe my colleague Nompilo has in addition. Thank you.
Yes,
hello, everyone. Yes, thank you. Yes, I think Dr. Kambale has rightly said very well. And yes, with those that are more hands-on with the key population, we are really working with them, including our national office within SNAP, who then able to liaise with the national office, the support group, or where they are leads of these key populations spots. So in that way, we've been the refills. So far, we're getting a feedback, and it seems like everything is going fine.
I don't see any questions in the Q&A, so if I may ask the panelists again to just share with us from their experience so far during this, within this COVID era. What do you think are the systems that need to be put in place to safeguard access to ART during lockdowns?
Sorry, Peter, we didn't get your question.
Sorry. I'm asking to share with us, based on your experience, what you think, what systems you think are needed to be put in place to safeguard access to antiretroviral therapy during these lockdowns?
Okay, thank you. Maybe I will start. So I think to prevent the transmission of COVID-19, the key intervention is to limit as much as possible the contact with suspect cases or the contact with healthcare facilities. So for us, I think the country is happy now that all the partners are putting their resources and hand together to scale up community commodity distribution. So for us, this has been a great opportunity to even integrate other services, not only ARVs, and we are hardly work to scale up DSD in Eswatini. So I think that is one of the good, how can I say, the good advice I can give to other countries. So community distribution of ARVs and other commodities is key to fight COVID-19. Thank you.
So if I can comment for Liberia, with this experience, what we've identified as some of the key systems will be a monitoring system, because we've seen that this was a bottom-up initiative, and going along, it is very important for us to be able to track who gets refills, who needs refills, and how the process of how this refill gets to the recipient of care. In addition to that, a clear communication pathway. So how messages or how the information goes out to the recipients of care, how services are offered to them so that they are aware that this is available and that they can still access ARVs even in the presence of the COVID-19.
Thank you very much, Amrata. And have you any other contributions from the panelists?
So for Sierra Leone, I think it's also similar to what Samreta mentioned. We do have some issues with data to inform our planning and operation, especially now that we're doing community refills, and also to add drug availability out there to ensure to prevent stockouts. Also, I think this is a very good opportunity for us to strengthen collaboration with community groups, and even also communication within our ART sites. So that's where we can be able to make informed decision and also give our clients, the recipients of care, the best possible treatments they would prefer. So for now, I think collaboration with other community stakeholders is very key in our community, because we do not have the human resource, we do not have the logistic resources. So we do need to strengthen some of this collaboration and expand on our services to ensure that we scale up to different areas, because currently it's only about 20% of our health facilities in the country are ART sites. So I think this is some of the lessons we're learning, and hopefully we will try to see how we can implement some interventions to help with this.
Thank you very much, Dr. Bandy.
Yeah, I think for Kenya, just in addition to what has already been said, without repeating, is what you've seen is really, we have really had a lot of virtual coordination of services between the national, the county, and even within the counties. Most counties now have virtual weekly coordination within the partners and the other stakeholders to be able to thrash out issues and come up with ways, because with COVID, we realized the situation is very fluid, and with time, really need to come up newer ways of delivering ART. We have even seen some of the counties coming up with innovations like having ART delivered through courier systems, and even some are for the KP services that are considering having a mobile methadone clinic to be able to move around the methadone. So I think just the regular virtual coordination between all the stakeholders and continuous engagement with, of course, our patients.
Thank you very much, Dr. Momani. Finally, if you will just share with us the knowledge of other non-HIV programs, like the SB program. Are they using any of these innovations?
Can you please repeat that?
Yeah.
If the non-HIV programs like the NCD programs, whether they are using any of these innovations that you described to kind of make sure that people receive their drugs during this lockdown.
So Peter's line is getting a little bit blurry. This is Miriam. Just in case you didn't get that, the question was about whether any of these fabulous innovations are being used by programs other than the HIV program, like programs for non-communicable diseases. Are people with hypertension also getting home delivery, that sort of thing?
Thank you, Miriam.
In Liberia, no.
So in Eswatini, we are closely working with the other units, including the TB and the NCD program, and even SRA. So all commodities like NCD drugs, TB drugs, and family planning supplies have been also included into the initiative. Thank you.
Yeah. For Kenya currently, no, but I think from just the recent the last 1 week discussions we're having around how we can bring in some of these strategies to mitigate COVID on HIV and TB and even malaria. So there are some discussions on how some of these models can be applied across the other chronic conditions in Kenya, but I think we are yet to work on this and be able to share this with the other facilities, something we are working on.
Sierra Leone is a thing. We're yet to fully use this model in other programs, even though some form of differentiated service is going on for like malaria. But as a country, I'm not too sure about if we have fully implemented home delivery for other services like NCDs. But these are discussions that are ongoing. Yeah.
Sure. And if I may also ask, pediatric dietary also being delivered through some of these innovations? How are we ensuring that the kids are accessing uninterrupted ART during lockdowns?
So in Eswatini, as teen clubs have been suspended, so children and adolescents are also receiving their supply through the community ARV distribution. Thank you.
Thank you, Dr. Kambale. Any other contribution?
Yes, in Liberia, the home delivery is also available for children during this period. Especially, we try to do family packages as much as possible where mother and child are recipients of care. The service is provided to both during this period.
Great.
Yeah, similar for Kenya. I think during this COVID-19 period, for where we are delivering ART to the community and even to the homes, we are using a family approach so that if there's a child in the family, they will also benefit from the distribution of treatment to that family.
Thank you.
In Sierra Leone, we also ensure that like children also benefit from the same months multimodal dispensing, and everybody, like all recipients of care, regardless if you're pregnant or a child or an adult, you're eligible for home distribution.
Great. Thank you very much. Clearly, I mean, COVID and these lockdown situations are reminding us to strengthen our multi-sectoral relationships and also to create new ones and be more innovative, more creative in our approach to differentiated service delivery. This has been a very interesting session, and I would like to thank all our panelists for doing such a wonderful job. Thank you very much. Before we wrap up, I want to extend an invitation to all of you to our next week's webinar. It's going to be on supporting TB preventive therapy for clients accessing DSD during COVID-19. I'm sure it's going to be another interesting one. So please make time to join us. And I want to thank all of you for joining us today. Have a great day. Thank you.